So welcome everybody. And what I wanted to do today, especially, is to take a moment to just acknowledge the importance of what we do here every month, and really to share the gratitude that I feel for all of you attending and for everybody who's presenting today. This particular program is a 2-hour program. We usually do these for 90 minutes. But this is going to meet the needs, and we'll talk about that for many of you who need continuing education credit in the healthcare profession. Again, this is another one of our programs with the Big Bend Coalition Against Human Trafficking, and welcome to everyone. This is our panel today. I'm very excited if I can go through this slide, and then if we need, we're going to share the presentation time with you today, and you can see the great expertise of the people. I mean, I am who I am. I'm the executive director of STAC and a lawyer who's worked in this area, but you can see who's with us today. Now we usually do extensive self-introductions, but I think today, because we have so much content, what I'm going to do is let you know that Dr. Suzanne Harrison is with us today from the FSU College of Medicine. You can see her many qualifications, and we have worked so closely with you over the years. Suzanne, it's great to be with you again today, as ever. Graciela Marquina is our Victim Assistance Director for STAC, and is a very experienced, not only is she a very experienced social worker, she's a very experienced case manager, and has done wonderful work for us on human trafficking, assisting survivors. And by the way, I have to tell you, we have the biggest caseload we have really had since the inception of STAC. You know me, I just said who I was. I also co-chair the Big Bend Coalition Against Human Trafficking, and also Allison Wyman, who we have just started working with in the last several months since COVID. She is the director of our Big Bend Area Health Education Center, and a guardian ad litem, and has done terrific work. So we're very grateful to our panel today. Thank you for being here. So moving ahead here, what I'd like to do right away is just start to fill you in on what we're going to be talking about today. We have a very dense program for you, a wonderful program, I'd say. We are also going to be sharing with you a couple of videos to highlight this issue of human trafficking, healthcare, and with a special focus on telemedicine. This is really something that we have now in our lives thanks to COVID. But from what I could tell, it's not going to go away. And I think there's some good reasons for it not to go away in terms of taking advantage of this technology and assisting in greater access to healthcare for many people. But with human trafficking and people who are currently in trafficking situations, there can be dangers, and we're going to be highlighting that. So as we go through, we'll have that new special twist. Even if you've had a human trafficking training, healthcare training with us or others, you're going to probably get some good new information. So we'll be talking about all these things, talking about what trafficking is, recognition, approaching the patient, resources in your community. It definitely takes a village, as you know, with this issue, the importance of documentation and reporting, advocacy, because you are more than who you are in your professional lives. You are neighbors, your friends, your family members, your members of PTAs and faith communities, and in all of the places really that you live your life, you could be someone who assists a survivor of trafficking. And then finally, we're going to talk about insurance options. Allison is going to help us figure out that vital piece of helping people to be safe. Our objectives are also very clear in terms of moving forward with this, and talking about both sex and labor trafficking and the scope of the problem, how to recognize red flags. We'll talk about this approach to a patient using telemedicine through our video, our wonderful scenarios that we have. And again, these are details on what I just described. So first, about trafficking. We know this is a super important topic. healthcare professionals are trusted greatly to be able to be the ones, and maybe the only ones, that victims will share information about victimization with. It's a safe place for disclosure, and it clearly provides us the opportunity to move forward in many ways, both to help the patient to be well and to serve the greater interests of society. You might know that trafficking is big in Florida. Unfortunately, we're third in the nation when it comes to this issue. These are calls to the National Human Trafficking Hotline, and you can see they've been growing steadily over time. You can see where we cluster in this, and even in our Big Bend area, even though there are fewer dots across the Panhandle, we know this is a vastly underreported phenomenon. And, one healthcare provider shared in a book that I read recently that his calculation was in a 20-bed facility, he probably saw at least 100 trafficked persons annually. This could also mean that, approximately, probably, is what studies have shown, between 30 and 80% of people who are trafficked do have contact with the healthcare system. Elements of trafficking, starting out, let me just share with you, these are the basics. A trafficker can be a recruiter or someone who moves or obtains somebody. We always need to show force or fraud or coercion unless there is a child. So for example, someone could be invited to come to Florida to work in landscaping, but when they get here, they find they're working in a cantina and forced to have sex. They have thereby been defrauded, right? They've been made a promise that didn't pan out when they arrived. And then they're coerced because and you'll find out more about these kinds of means that traffickers use. They're coerced to continue working, or else, there are threats to their safety, to the safety of others. And then the purpose is always around some sort of labor, some sort of service, and very often accompanied by a debt or slavery. Trafficking and smuggling are sometimes confused, and we keep this slide in here just so you keep this idea of trafficking being something that is coerced, and the person is the focus of the coercion, of the exploitation, of the crime. That person loses all sense of freedom and agency, and it's involuntary. Someone is smuggled, it's me being asked to cross a border and asking someone for help to do it. And even though the conditions might be horrible, I am wanting to do that for whatever reason, a better life, etc. Always involves crossing a border. Trafficking never requires the crossing of a border, but it could include that. So you see, persons are commodified, they're trafficked, they're brought across an area. It could turn into trafficking. So know that if a person might start out like many of the people we've assisted in a smuggling situation, it can turn into trafficking. Here are some of the trends that we have seen. First of all, we know that COVID-19 has made it worse. Traffickers are nimble, they're wily, they take advantage of crises, whether they are economic, health-related, natural disasters. We in Florida are about to enter hurricane season June 1st. We know traffickers will take advantage of that. We're about to see an eviction tsunami with more and more people economically insecure and unstable. We know this can lead to greater desperation of people and more people that traffickers can prey on. And you can see there's some other trends here to notice in terms of the opioid use and the explosion, really, especially for youth, of online exploitation and recruitment into sex trafficking by traffickers since, really, again, the onset of COVID. And now I'd like to turn it over to my colleague, Graciela.
Thank you. Who are the people at risk, or who are the victims of this, the traffickers? So if you can think about one word that will help you to identify who could be at risk, is the last sentence at the end of the slide: any vulnerable person. So anyone that has vulnerability, it is at risk. For example, we have runaways in unhoused youth. They are at great risk, of course. We have seen that sometimes youth leave their houses and they engage in survival sex, which is exchanging sex for a room or meal or something like that. If they are youth, the people that are doing that to them, they are traffickers. Other kind of a population is elderly people with people that had also mental illnesses. The LGBTQIA plus community is absolutely at risk. I guess here we still have to work with people and organizations to help them, but they are completely at risk. Immigrants, people unstable, people that are don't have a stable housing, and of course any substance use. So in general, this is, you know, a group of people that might be at risk. So who are the traffickers? I wish that I could give you some kind of one sentence and possible even one picture, but it really can be anyone that, of course, has an evil heart. But it could be organized international crime. It could be neighbors, friends, and relatives. It could be somebody that is posting as a boyfriend or a business professional. We have also seen labor subcontractors. There's a construction, there's a construction subcontract people. They don't know what's going on, but the people are being trafficked. If you go to the next picture, you can put in the chat, who do you think, I know this is mugshots, but who do you think this one is not a trafficker from this picture that you are seeing in here? Anyone? Or it's too obvious? I just said the answer, right? Well, all of them are traffickers. It is really sad to see this. All these pictures are traffickers. The two women, unfortunately, are mothers. I was saying it could be anyone. They were trafficking the daughters. Actually, the very top picture is for about 3 years ago, close to this area. There is this gentleman. For example, the bottom of the picture is a man that was luring women from prison to come, and he would put money in the commissaries, and then after they left prison, he would traffic them, basically. So you see all these schemes of how the ways that traffickers use, it really amazes me, because the trafficker can use even cultural or religion or anything that will control the person. Why do they stay? We still have that question, and it's difficult to understand. But the reality is that trafficked people usually are, they went through some or have been subject of violence. The traffickers threat against them or against the family. They get isolated, of course. Sometimes they owe money. They think they owe money. And the traffickers also use threats like, I am going to call immigration because I know you are here undocumented. And also remember that there is this unhealthy bond, oh gosh, I forgot the name of the bond specifically. But it is an unhealthy bond that develops the person that is with the victim with a trafficker. I think it's quite
so I'll go ahead and take over from here, Graciela, if that's okay. Hi, everyone. I'm Dr. Suzanne Harrison. Robin introduced me earlier. And I'm going to talk to you a little bit about recognition of victims of human trafficking in the healthcare setting. I assume that many of you are healthcare professionals of some sort. So that's what we're going to do next. And just to answer the question that Graciela was asking herself, she was referring to Stockholm Syndrome as the form of traumatic bonding.
Thank
So
you.
why are we talking about this? So, you know, there have been several studies published over the last 5 to 10 years that really demonstrate that healthcare providers are not recognizing human trafficking in the healthcare setting. And this study that is referenced on this slide actually demonstrates that almost 88% of survivors that were in this study reported accessing healthcare services in their trafficking situation during the year prior to the interview. And of that, at least 68% were seen in the emergency department. None of those folks that were seen and had illnesses or injuries related to their trafficking were asked by the healthcare providers in the emergency department. And this is just to demonstrate that we do have an issue. We need to continue doing training, and that's why we're here today. So if we could move on. So again, we have healthcare providers missing the signs. Part of it's a lack of training. Part of it's discomfort with the content area and the busyness of our practices. It is just, almost untenable sometimes with the number of patients that need to be seen and the lack of resources to really be able to sit down and truly listen to a patient. But even in the ideal situation, there are healthcare providers who are not recognizing the signs of human trafficking. And even when they do, they really don't know how to respond. And so part of our answer to that is to provide these trainings to as many people as are willing to listen so that we can mitigate some of those barriers. And so just to drill down to what are the barriers, I mentioned this already, but the brief interaction time we have with our patients, they can be very resource and time intensive. And as a healthcare provider myself, I want to just emphasize to everyone that we are a team and we don't have to do this independently. So it's important to find who those team members are in the situation that can help you. And if you have a lack of expertise, to attend trainings and to get additional training that will help you in those areas. Our patients specifically are often at-risk individuals, as Graciela was so eloquently describing, that come from really marginalized groups. They've been severely traumatized, they have multiple issues and really complex needs, and sometimes even their injuries are not the most important. So it really is important that we prioritize what the patient identified needs are in caring for them to help mitigate some of our own resource and time stressors. And I think that helps a little bit. And then I think we have to look at this from a systemic perspective as well. In our culture, with our history of colonialism, slavery, and exploitation over the centuries, we're just really set up for this in this country. Not to say that this doesn't happen globally, but we're talking about what's happening right here in our backyard. We also have a society that sort of has, hypersexualized everything that we do. And so all of that contributes to the acceptance of sex trafficking. So that was my cue to hurry up and move on to the next slide. Thank you, Robin, for doing that. I want to talk about the red flags, or just mention them a little bit before we go on to some of our role plays. So it's really important that you recognize when a patient that you're caring for gives you a history that is inconsistent with the injuries or the physical exam that you're seeing, or there seems to be a scripted component to their history, such that if you ask a question that's not part of their script, there's that split-second hesitation because they haven't considered the answer yet. That's your in to ask more questions. You may see patients who are unable to provide an address or even understand what city they're living in. They may claim to be just visiting and be really vague about that answer. You may see patients who have an unusually high number of sexual partners. And that's not to say that patients who are not being sex trafficked can't have an unusually high number of sexual partners. So withhold your judgment, withhold your surprise, and just ask a few more questions about that. But it really should, raise your instincts to think about, what is happening here? Is this voluntary or is this involuntary? You may see patients who are seasonally or situationally inappropriately clothed, and that may be a reason to ask more additional questions. You may see patients, particularly with sex trafficking of minors, who appear to be much, much younger than their stated age. So I'm talking about the adolescent who tells you they're 21 or even 18, but you look at them and you think they're 12. So pay attention to that. And we're going to offer you some mitigation strategies and some other tools later on in the session. Again, I already mentioned the discrepancy between history and observations. That's so important. You might also see patients with severe trauma, malnutrition, and dehydration, and you really have to worry about how much control they have over their environment. Again, these are red flags. It doesn't mean you've made a diagnosis, but it does mean you need to ask more questions and do a more careful exam to sort of sort this out.
Thank you so much, Suzanne. This is a lot to deal with and a lot of information. But what we're going to do next is I'm going to ask Chris to queue up to play the video. And what you're going to see here before you start it, Chris, is you're going to see a dramatized version of what a telehealth visit would look like in a labor trafficking situation, with Dr. Harrison being the doctor, doing the physician, and someone you might also recognize, Ernestina, coming to see her for some care. We have questions that we're going to process with you, so please pay attention to any red flags, pay attention to how Dr. Harrison works to build trust or not. We'd really love to see your reactions to this particular video, and we will also discuss it. So we hope this will be very interactive. And okay, Chris, take it away. So Dr. Harrison and Graciela, thank you for doing that. I thought that was a really nice depiction of what could happen in a telehealth visit. And let's open it up. First of all, could I ask each of you if you would like to make any comments, and then see in the chat if we have any people talking about any red flags they might have seen about Ernestina and whether or not she was being labor trafficked. And as they come in, do you want to mention anything in particular? I heard another one today when you started with the phone number, Suzanne, and Ernestina said, they told me not to call anybody, like instantly recoiling from the idea of even using a phone. That was a red flag.
Yeah, so people are putting things in the chat box. Her employer was standing next to her and didn't want her to speak to the doctor. She kept looking at her employer. She appeared anxious, disheveled. Employer was in the room and client said she was alone. Apprehension to speak, wouldn't answer without looking at her boss, kept looking for answers, looking off screen. So yeah, definitely. Graciela is an amazing actress.
Thank you. My son too.
Yeah, that was
He was a lawyer.
And what about telehealth in general? I mean, how did you all think about this? Some of these questions, first of all, what did you think about telehealth? And what did you think, Dr. Harrison, as you tried to build health, build trust, how was that different from having someone in front of you? What was that like? Because you both got into your roles very well.
I think telehealth puts a barrier in front of us or between us, that it makes it difficult to really connect. And so I found myself getting closer and closer to the computer because I wanted to be with the person. But I do think it's difficult to know, even after she said her employer left the room, it's difficult to know if that actually happened. Although she quit looking, but I have no way of verifying if her phone's off, if he might be able to hear what's going on. And I felt at a disadvantage. I couldn't touch my patient. I couldn't ensure that our conversation was private.
Mm-hmm. Yeah, those are all barriers that we see. On the other hand, you were able to kind of make some additional, make some kind of connections with her so she could see you in the future as a possible resource. Graciela, what do you think about some of the red flags you put out there? And
Yeah,
it almost felt like your body changed after your employer left the room.
Yeah, definitely. I think as Ernestina, Dr. Harrison kept asking how was the injury done. I felt that Ernestina didn't say the truth. I mean, she kept going and on about something. In my head at that time was in reality, the accident occurred with a door where somebody, did something on her hand. But again, it wasn't, I think as a physician, Ernestina started feeling well because the doctor was concerned about her health and about honestly saying, I am concerned about your work situation. And it was done in a way that Ernestina felt that there is somebody here that, might not say completely everything right now, which I don't think that ever happens. The whole story doesn't happen in one time, but having her concern kind of open, I think, something on Ernestina.
Very good. And what about some other comments in the chat? Do we have any other people weighing in?
We have people making comments about how difficult telehealth makes to make that, creates to make that connection, talking about asking questions repeatedly and particularly about wanting help.
Yeah.
Comments about Graciela's acting.
Definitely a positive. Well, I'm going to go to the next slide. We can continue to talk about this scenario, and maybe you can. I'll just weigh in a little bit. You can see that it's a possibility that she was injured. Maybe there wasn't protective equipment. We didn't get into ideas about where she was living, but clearly there was some lack of agency that she had about using the phone, or feeling like she had to stay working to send money home. She definitely felt cowering in terms of abused at work and threatened. We don't know really about, she didn't talk about debt, didn't talk about housing in particular or breaks, but there was definitely a sense of fear about who was paying for things. I think the issue of debt was brought up on this scenario because she was worried about who was going to pay for the x-rays. And, even though work comp exists, that who knows if this trafficker complies with all those laws and requirements. So there really is a lot of the red flags were here. I'd like to move on to the next scenario now in terms of sex trafficking. And we will have a similar discussion, and we can compare and contrast again. So let's talk about this, and thanks for asking the question in the chat there, Suzanne. It looks like a lot of people had some good responses showing the kind of the demeanor and what the patient was communicating. So what are some of the other things that you all saw? What kind of other red flags or any of the answers to these questions? What did you think about in terms of this being a helpful interaction, telehealth wise? Is there anything you think we should work on improving or could have been done differently? And really, since we've got both of these under our belt, so to speak, now, if anybody has any questions or observations about the last one, if you want to compare or contrast, feel free to do that too.
I have to say that for both interactions, I think it's great that the physician, in this case, Dr. Harrison, was explaining, even I am writing what you are telling me just to keep track. And it's just those soft things, how she was explaining things, Dr. Harrison, made a situation less stress for both of them. I think this interview was extremely hard, and still I think Dr. Harrison was able to talk directly with her and say, you are an adult, this is your decision. It was said at exactly at the right time. I really like when Dr. Harrison said, this is going to come probably personal, but I am, asking questions to get a better picture. So she was explaining everything that she was doing and saying, and that I think helped the situation, because this client was very reluctant to even admit that she was in trouble. She didn't know, she doesn't know.
Yeah.
So I'd like to add to that I think that, it's very difficult to start with a patient that you haven't met, recognize that there is potentially a trafficking situation at play, and get a patient to disclose in a very short period of time. So if I have developed a relationship with a patient, have developed any trust at all, and can get them some resources and a follow-up appointment, I feel like I've done well. So I don't expect people to trust me enough to tell me everything on the first visit. And so with patients that I'm very concerned about, I want a quick turnaround. Even if I don't need it, I want a quick turnaround so that I have another opportunity to build on that relationship and perhaps offer additional resources. That's sometimes difficult to do, but I think we have to think of ourselves as this big team. So while it's great if I can have the follow-up appointment myself with the patient, if I need to connect them with my nurse or with a social worker, or if I'm in the emergency room and I need to connect them with a primary care physician in an outside facility, if I can make that connection and make it personal, then I think it's more likely to happen. So there's, we're just one big team, and we need to recognize that.
Great point. Anything else in the chat you'd like to highlight, Suzanne or Graciela? Any questions that we need to address before we move on?
Well, there's just a lot of discussion. There was a little bit of discussion about why I told the patient that I was taking notes and what I was writing down. And now there's a question about the patient requesting a copy of my notes. I wouldn't have a problem with that. They're usually just scribbles. When I am with a patient in person, I make a point of showing them what I'm writing down. And it is part of my way of keeping track of the patient identified agenda and my provider identified agenda, because they're not necessarily the same, as you all know. We are concerned about sometimes a different set of things than what the patient brings to us. And so that's where that starts. But absolutely, if the patient wanted a copy of my scribbles, I don't have a problem with that.
And one of the things about this scenario, I think it's really good, is that as I mentioned earlier, that we're looking forward to a rent tsunami, and forward in a bad way, to having so many people be evicted or be at risk. And we've already heard of cases where landlords are essentially saying to women, yeah, have sex with me and I won't evict you. Now that is a form of trafficking, because it is forcing an exchange for sex for something of value. It doesn't always have to be cash. So understand that you're not always going to see what I would say a Hollywoodized kind of version of what sex trafficking looks like. It could be something, it could be one single person being trafficked by one other person, and in a maybe more limited way. We hear of more sensationalized stories, which certainly do exist, don't get me wrong, and they're all horrific, but it's I think it's very good to kind of open up everyone's kind of awareness to this could be happening on a much smaller scale than we usually see, or certainly that's depicted in your, usual SVU shows on television. So, so thank you all so much for this and for your participation. We can continue the reflections and the discussions as we go forward now too. So let me turn this back over to you, Dr. Harrison.
Okay, so I think that most of what's on this slide we have covered, but I do want to spend just a moment talking about branding. So this has changed over the years, but many patients who are victims of sex trafficking, we've identified because of various branding, often with tattoos. And you can see two photos here. These are real people who were trafficked, and the person in the bottom photo was actually discovered in the Tampa area. And that's a real photo. That trafficker didn't want to damage the skin that was visible, so tattooed women on the inside of their lips so that it didn't impact price. But it's really important that we think about all this. Most recently, we have traffickers inserting RFID tags into their victims, and telling them that they can be tracked that way. It's not actually true, but the RFID tag could be scanned and then someone perhaps sent back to their original trafficker because of that. Those are the tags that we put in our pets, that the vets put in our pets, and you can buy them on the internet. But the rest of this slide is really just about more indicators of sex trafficking. And so I'm not going to go over all of those. This slide, I think, is really important. And again, I'm not going to go over everything that's on the slide because you can all see it. But for me, the patient's body language and their demeanor is so important in identifying whether or not they're able to have control over their own life, their own body. So when a patient has poor eye contact or seems unduly subordinate or hypervigilant for any reason, I worry about who might be controlling them. Now, that doesn't mean they're being trafficked. It might mean they're being abused. It might mean there's something else going on, but it is a sign for me to dig a little bit deeper, to take a moment, to take a breath and think, what's going on and how am I going to proceed with this encounter? But really think about anything that could indicate a cry for help. We see patients who are being trafficked who are very depressed. There's a significant increase in self-harm behaviors and suicide. We see a lot of substance abuse in these populations. Some traffickers use substances as a way to control people, and I think someone put something in the chat about that with the second role play, that she was acting as though she was maybe on some drugs. But even if the drug isn't desired, addiction is often a consequence of that problem. We also see patients who have this sort of loss of sense of time because they've either been drugged so much or they've been held in captivity and don't really know how many days have passed, that sort of thing. And so again, those are very important. These are control indicators, and I'm sure you've all been aware of these and know about this, so I don't need to spend a lot of time. I do want to say that we don't ask questions when there's another person in the room. So you want to see every patient alone at some point for some portion of the visit. If you sense that that they're accompanied by a controlling person, you may have to be a little bit creative about that, but you might put the patient in danger if you ask questions in front of another person. So be very careful about that, and be very aware of these control indicators. Again, might not mean trafficking, but you're going to uncover a different problem. You'll certainly uncover something if you pay attention to this.
Okay, so we wanted to take a moment too, and you've all reflected on this, particularly in the first one when the employer was visibly present on the telehealth visit. And because we wanted to also talk about, telehealth in general, since it's probably here to stay. So what are some of the pluses and what are some of the minuses? One of the things I have to say about you, Dr. Harrison, is that everything you did over the telehealth, over the teledoc visit, you would do in person as well. You would be reassuring, you'd be building trust, you'd be letting the patient set the agenda for care, you'd be making sure they were alone, all those things as much as possible. So, so just to know that this is not like only a telehealth way to interact with folks, of course, but what about some discussion about this? Do we see anybody weighing in on the chat about what do you think some of the advantages are? What do you think some of the disadvantages are with regard to telehealth? And Dr. Harrison and Graciela, do you want to weigh in on this?
So I think there have been quite a few people on the chat talking about this and almost talking with one another, which I think is wonderful that we're able to do this. Clearly, the advantage is access to health care, right? And particularly during a pandemic, but we mustn't forget that people have access problems all the time for a variety of reasons. And we've been trying to solve that problem for eons. So I think that having telehealth is really important in that, if you're from a rural community, you don't have transportation, there are ways to have access to healthcare. If you're elderly and you can't get around, or, there's just a multitude of reasons. And I think that's mostly what we're seeing in the chat. And the disadvantages are really that you can't touch a person. You can't interact with them in the same room. You can't be sure that it's absolutely confidential. And it feels different.
Mm-hmm. And the danger, we were on a webinar with a survivor who said, I cannot imagine if I were currently under the control of that person that they would have even allowed me to do this or to do it in person. So, and then again, how do you, could you imagine doing any of these visits, Suzanne, if you could say the person refused to leave or you definitely thought they were still there, what would you have done differently?
Oh, that's such a good question. I think I might have insisted that he pull up a chair and sit down so that he participated as part of the visit. Partly because he didn't want to, and forcing that issue that I need to be able to see you if you're going to participate. And I might have directed some questions to him about, whether he was present during the injury, what he remembers about it. Does he provide a workman's comp for his employees? That sort of thing, the typical kinds of questions that might get asked of an employer. I would have tried really hard to annoy him so that he left.
It's something to say. You surprised me when you just said that you'd ask him to sit down. We do, when we talk about this and we are not on telehealth, people talk about requiring somebody to go get a urine test. So, sir, you have to leave, or you need to do this paperwork, none of that is present when you're in one of these visits. Do we have anybody weighing in on this? And Graciela, do you want to kind of chime in on some of the advantages, or Allison, maybe you have some thoughts as well, advantages or disadvantages regarding telehealth?
So someone in the chat box said one of the disadvantage is confidentiality. And I'm hoping that really speaks, the question is more surrounding other people in the room. Because I do want to reiterate that, when a physician is having, or a provider is having a telehealth visit, there is complete confidentiality on the provider side. We recognize all of as it was just in the room, to protect the patient's information, protect the diagnosis and all that. So I just wanted to provide clarification. So yes, the disadvantage may be confidentiality on the other end, but not from the provider.
Yeah, I need to also remind everyone that the traffickers do or have taken victims to the hospital. And it's hard to believe, but remember that the victims are commodities. So they want the person to keep working. And I think that the telehealth will help to provide that trip, like a Dr. Harrison was saying, that trip to the hospital and trying to avoid all these questions and fill out forms or whatever it is. So I hope that the victims ended up getting more exposure to physicians and also the care that they need.
Mm-hmm. Mm-hmm.
Agreed.
Yeah, yeah. Well, very good. Any other comments in the chat before we move on?
No, I don't see any.
No, I mean, they're talking to one another.
Okay, good, good,
They're
good.
coming up with great ideas.
All right, what are some of those great ideas? You want to quickly share?
I mean, it's more of the same. There was a person who talked about how my husband was walking around behind me, and that was concerning and distracting. Concerning for confidentiality, but also distracting, which is absolutely true. And I talked to him about that later and kicked him out of the house today. There's a comment right now that says, when it's not a relative, it should be a red flag to the physician. What is the relationship to the person? And that is absolutely true, but people lie about who they are. So don't be afraid to ask difficult questions. And don't be afraid to allow other people to ask questions. So if you want to have this really trusting relationship and not be confrontational, assign someone on your team to ask the more difficult questions. Play good cop, bad cop if you have to. There are all kinds of creative ways, and I can see by the types of comments that we have a group of people who is well versed in providing this type of care. So we have something to learn from them.
Well, you know what, on all of these, and I wish we could just have a Zoom with everybody's face, all 100 and whatever of us there are on now, so we could all be our own students and our teachers as well. So I'm so grateful for all of that. And so let's move on. Graciela, do you want to give us a little more on victims' perspectives, maybe building on what we have just learned?
Yeah, quickly, for example, with Ernestina, definitely she has some fears. Sometimes this language barrier, and that was hard not to for her and for the physician trying to figure it out. But from her point of view was, I need to send money to Mexico. I haven't sent money. I need to pay $8 for the mask. So it's again money. She was concerned about if the social worker was Dr. Harrison's boss, because it seems that Ernestina was working in positions like the boss, and who is this person and now get involved in. So Dr. Harrison handled it completely fine. So Ernestina was really afraid about the whole situation. The second video that we saw is Sharon wasn't in a place where she was recognizing what was happening to her. And we have had participants of our program where it is hard for them to see. It's not that black and white situation. It's hard for them to see where are they. And as you saw, she wasn't ready for anyone to come and say, hey, Dr. Harrison, put the seats, and then, we cannot do more than that. Later on, probably she will have the traumatic bonding with a boyfriend that we have seen all the time, Stockholm syndrome. And of course, she didn't identify herself as a victim. She had still some control over the situation. For us, we do use trauma-informed care, and I hope that everyone knows what is that.
Mhm.
So I don't know if I need to clarify that.
Yeah, and I think maybe what we can do is think about, we probably need to have one of these programs that focus on trauma-informed care in
Right.
this context. So thank you.
Yeah, and as Graciela was saying that, I was thinking that it needs to be culturally competent trauma-informed care, and so include both of those components. But I want to switch gears just a little bit and talk about your general approach to the patient when you have concerns about them being trafficked. And I already talked about how important it was to examine or interview the patient alone, and how important it is that you don't ask questions in front of someone that you are concerned might be abusive in any capacity. It is really important to use a trusted and reliable interpreter that is not connected to the abuse or the trafficking in any way. So it's got to be somebody who's trained. And we have language lines, we have Google Translate, and we have very skilled interpreters available in most of our institutions. So don't shortcut this and use the person who happens to be with them, because you never know what will be translated or what won't be translated. If you are encountering that person who looks so much younger than they are, they're telling you they're 18 and you think they're 11 or 12, think about checking the FBI missing persons database, or having someone on your team do that, because you may find that this is a child that's been reported missing and is being trafficked. And so it's really important that we do our due diligence in the moment. As Graciela has said so many times, she is the expert in confidentiality. I try to remember to reassure people frequently, and to be absolutely truthful in how I respond to them. But these patients who have no control over their lives, for whatever reason, need to be reassured more frequently. So just saying once at the beginning, this is confidential, you signed a form that said it was confidential, right? So you're done. They really need to be reassured frequently. I like to just be really careful at the beginning and proceed without pressure. So I don't want to pressure someone into disclosing something that they're not comfortable doing. So I'll ask around it or re-ask it a different way. I like to let the patients feel like they're in as much control as possible, regardless of the reason that they're coming in. It doesn't have to be an abusive or a trafficking situation. It's the patient's healthcare appointment, and we need to put their patient identified agenda before our own. And many patients are not aware of their rights. Like in our depiction of Ernestina coming to see Dr. Harrison, she did not know that her employer was responsible for payment and that she wouldn't have to pay that back. And so it's really important that patients understand what their rights are to the extent that we have that knowledge. If you don't have that knowledge, there are case managers and social workers who do.
This is some of the initial screening questions, some examples, and the situation is going to be always different. I usually, what I do is attend immediate needs. If I see the person that might be exhausted because it's walking all the way to my office, so I offer out water, very basic needs. And then the conversation goes more about how do you come here? Do you have a safe place to be? Who was driving you? Things like that. Then if this person has, clearly that somebody had abused the person, then I will start asking, but it really depends on the situation, me as a social worker. The next slide is secondary questions. And again, is like a deeper. Remember that whatever time you do, I do always consider time for safety planning, safety about the person and what person after he leaves the office or whatever we are, what is it going to happen with a person. So I usually design a little, very simple safety planning after I have a kind of assess with my secondary questions, what is the issue.
Okay, so thank you. And there's so much, we could do a whole program on safety planning, Graciela. It's just important for us to mention that and to keep it there. So we want to talk a little bit about connecting to resources, and this top line is one of the most important things. I think Dr. Harrison always already said it, which is you are not the service provider, but you're linked to the services in the community. So within your institution or office, you've got a team approaching, but know that the whole community really should be there to provide the services that a patient needs, assuring them that they're not alone and that help is available is really, really important. And Graciela, here's some examples, right?
Sorry, I was trying to answer somebody from the chat. Really interesting question, if I can mention.
Yes, please.
Robin. So then Gabrielle is saying the employer, probably the employer is not going to cover the cost. So then the victim is going to work harder and to cover that. And fortunately, and hopefully, you guys will get to catch one of the social workers or calling us, because there are ways that we can help for the victims to whether to pay or find a way or resources for the victim to get that help. So it doesn't have to be like that. We have now, it seems like more help and resources, and we know. So please call us. Social workers are magical. Okay, now I'm concentrating with this slide. Oh, well, yeah, I mean, again, going to under trauma informed, what are the needs, immediate needs for some of the clients? They are completely different. Sometimes they need immediately housing, sometimes they don't, but they need interpretation. Sometimes they need transportation. They might need some kind of income for that moment, or sometimes they need all of them. For long-term assistance, and this is very important that you know, when we start helping a victim and then it comes a survivor, it doesn't end there. It is a lot of things that we keep working on. Maybe might be legal assistance because the survivor now wants to reunite with the kids. Maybe wants to keep going with the counseling. Maybe substance use treatment. We have clients that are coming from other countries and very small villages. We need to put our minds as their perspective, and we cannot come and say, hey, well, we will help you with a Walmart card for you to buy your food, when the person doesn't even know what is a Walmart card, never heard of a debit card or credit card. So we need to go back to wherever they were and keep assisting to where they are.
Let me add one more too on that. I've just done training for financial institutions, and it's very, very common for traffickers to ruin the credit of victims, to exploit them, to make them open credit cards and checking accounts in their names. And it's very, very hard over the long term for them to recover from that, to start a new life. So really, it is a long-term situation. And we tend in this field to think about things like, oh, there was an immediate need because someone has just escaped a trafficking situation, but it truly is a long-term. So here are some things to remember. 911, of course, if there's danger, regardless, and just revert if you're a healthcare provider or anyone who's assisting survivors, is that you've got protocols in place already if there's any kind of danger posed, whether from a trafficker or from any other kind of threat. And know too that because the patient might have some fear related to law enforcement, either in their home country or because they've been forced to commit crimes as part of a labor trafficking situation, that they may be very fearful of law enforcement. So don't, anticipate that when and if you have to call police, it's going to be, immediately well received by that survivor. So the National Human Trafficking Hotline has lots of resources. I want you to know about that, both as a place to help It can be a tip line. They will connect to resources. STAC, we've gotten more calls from the hotline in the last week, I think, than we've ever had in our existence. Our caseload is exploding. So know that this is a constant thing for us to kind of keep aware that regardless of where you are in the country, that the national hotline is a resource. And then I know Dr. Harrison always says, you know, to have that quick connect again, to follow up, try to make that appointment before the patient leaves the exam room. So to talk a little bit about the documentation and reporting aspect, this is something that I often get a lot of questions about when we do these presentations. To first reinforce that as healthcare providers, you have two kind of main areas of reporting to keep mindful of. First of all, that you have to report to your local law enforcement, that's the county sheriff in the jurisdiction where you're providing treatment whenever there is a gunshot wound or life-threatening injury. And that's not just with trafficking, that's with any human being that walks into your care. So you have to report those two things. That's a call to your local sheriff. Adult, child, anyone, that is required under the law. Failure to do so is a first-degree misdemeanor. Now that doesn't mean that you don't have to do reporting to the DCF hotline. So let's talk about that. If you are assisting, supporting, providing care to a child or to a vulnerable adult whom you suspect might be trafficked, that is a call to the local 96 Abuse, 896 Abuse Florida hotline. And I've done a little research too in some surrounding states. Similarly, you know, a child who is trafficked is by definition a child who is being abused. So you must make that call. You can make it anonymously. There may still be follow-up in terms of if you're required to provide further information. And know that too, this is for vulnerable adults as well. So that's kind of an adult who can't care for themselves in their daily lives. Make sure you say that this could be human trafficking. It will ratchet up perhaps a response. It might connect immediately to law enforcement when that child protective investigator goes out. So it's really important to remember you have two forms. There's not mandatory for human trafficking, just like there's not mandatory for domestic violence reporting, but there is if it's that life-threatening injury. So Dr. Harrison, you want to talk about why documentation is so important?
Yeah, so documentation does many things, and it is really important. And we've talked about this a little bit with, you know, the note taking and what you share with the patient. So the components of the note that you write in the chart, regardless of who you are in the healthcare provider stratosphere, I mean, there's lots of different types of healthcare providers. And our documentation should complement one another. But we really want a detailed description of the disclosure if that happened, in quotations wherever possible, because we want to know exactly what the patient said. This can be used in the future for other things. A detailed description of physical exam findings with photos or drawings. If you don't have photo capability with your EHR, you could usually draw something and include that in there. Include your concerns in the assessment, even if the patient chooses not to take resources. Document that follow-up plan that includes all of the resources you provided in whatever safety assessment was completed, even if it was just a brief 2-question safety assessment. Include that in there. That includes even resources that the patient declined. So you want to document what you offered. And this really can benefit the patient, you know, with the court system or law enforcement following, you know, a healthcare visit. It can help to provide additional resources for job training, immigration relief, welfare support, and it really validates their concerns. But here's the caveat. With all of that, and you really do have to document all of that, I implore all of you to document in the same way that you would talk to the patient. So they may see their notes, and we need to be documenting in a way that is just as patient-centered as our verbal communication and nonverbal communication is when we're with them in person or telehealth as we're doing today. So that you are not, you're checking any judgment or negativity at the door when you start your documentation. And I say that because you know, my colleagues, me and my colleagues, we're not perfect, and we document things that are often inappropriate and hurtful. And so I want, in this day of EHR where people have access to things, just keep that in mind.
Very good. Very good. So let's talk about a few options in terms of how you can take action. First of all, share information far and wide and contact us at STAC or your local anti-human trafficking programs or some of the national programs. Post materials in many languages, continue this push toward training. Again, contact those of us in the field so we can assist you on that. And one of the things that has been mandated for those of us in Florida is that healthcare workers need to post signage that gives the National Human Trafficking Hotline information, a bit of information about trafficking in both English and Spanish. The Department of Health in Florida has a sign. We have signs on the STAC website. And if I could ask maybe Graciela to put the link in there as well to the STAC website, you can see we can give you hard copies of these posters, which we have created and are beautiful, and also provide those to you so you can download them. Here's a summary of what I just talked about already: the DCF hotline, the National Human Trafficking Hotline, and STAC information. And again, I put this in the chat. We will have this all available for you to watch and to listen to on our website later. Let me turn this over to Allison to talk about insurance. Allison.
Thank you so very much for giving me a little bit of time here at the end of this incredible presentation. I just wanted to talk briefly about some insurance options that are available not only for victims of trafficking, but all low income and marginalized populations as well as our working families. So I'm here representing the Affordable Care Act navigators.
Oh,
and
okay, sorry.
You're good. And really the most important thing to know about navigators is we provide unbiased assistance for anybody looking to sign up for healthcare via the Federal Healthcare Exchange. Next slide. Okay, so to be eligible for the healthcare marketplace, you have to be a US citizen or national, be a non-citizen lawfully present in the US. And what I want to really key on here, and it goes back to what Dr. Harrison was saying about documentation and reporting, is that our victims of human trafficking are actually eligible for, if they qualify for the T visa, they become eligible for benefits as part of our support of these individuals that have had these horrible experiences. So, you know, just document and reach out and make sure that you do what we can to provide the documentation. And finally, the individual cannot be incarcerated to be eligible for marketplace. The other key point here is that the open enrollment period has been extended to August 15th, 2021. And this is huge. We went from having an enrollment period of 6 weeks now to this open enrollment period throughout the summer. And this is huge. And already in Florida, we've seen a lot of people getting insurance via this new marketplace enrollment. And the other thing that's important is there's just, since with the American Rescue Act, their insurance is even more affordable now, and there's more benefits. So it's very important, even if you have clients that are already enrolled in marketplace coverage, if they call us up or contact whoever enrolled them, they're eligible for additional discounts. There's special, okay, thank you. That's
Sorry.
No, you're good. So this is, I want to emphasize that this is this is good insurance. And the Affordable Care Act really expanded health insurance in many positive ways. One is all pre-existing conditions are covered. Yearly wellness checks are usually free, if not always. Flu shots are covered. And what's important about the navigator, I said this before, is the unbiased but we also work across all the plans, and we'll work with the client to see, okay, you know, do you have a particular doctor that you want to see? Do you have a prescription that's most important to you? So we work for the best options with the client in a non-threatening way. Next slide, please. So as I mentioned, this is great insurance coverage. All the essential benefits are covered, and I'm not going to read this, but you know, maternity, newborn, hospitalization, prevention, and wellness. These are all covered as part of these plans. Okay, so there are a variety of plans available, just like there would be in, you know, from your employee perhaps. So there's the high premium, lowest out of pocket, which are the platinum care, and then there's the low premiums and highest out of pocket. And again, we work with the individual client to see what works best for them. So I want to just show some of these poverty guidelines to give you an idea of, you know, the types of income levels that are, you know, that are covered and that can receive benefits. So, you know, again, just take a look at this, and if you have clients that you work with, you know, please make them aware. And so, for instance, with the silver plans, well, with the new legislation and the Rescue Act that's passed, most people are saving now an average of at least $50 from what it was before, and those savings for the lowest income populations are even more. And in many times, the coverage is actually free. Next slide, please. So I mentioned some financial assistance, and without getting into the details, you know, those come in the form of premium tax credits. Next slide. Or reductions on your premiums. So again, the navigator works with the client to get the best plan for them. Next slide. We can also help with Florida Kid Care. And sign up help our clients navigate through that system as well. Okay, so we're Medicaid and benefits on the exchange. I mentioned this T3 visa. Usually there's a 5-year waiting period for immigrants legally in the US. But with the T visa, those individuals are able to qualify for these benefits immediately. And the other thing that's wonderful is it actually covers the family member. And this is such a huge, you know, imagine you're a mom who's being trafficked and you have children, or, you know, your spouse, or, you know, so it's wonderful that it covers the whole family, which is so important as people are trying to, you know, heal and recover and establish normalcy. Okay, so I mentioned, you know, what the marketplace looks like now. And I mentioned again, most important fact, it's open enrollment now until August 15th. But after August 15th, just like other insurance plans, there's qualifying events, and those are listed there. Okay. So how to enroll? I'm here in Tallahassee area, and so this is the top part is specifically mine, but there's navigators all over the state of Florida. And to do that, you can go to healthcare.gov or Covering Florida. And you know what? I'm going to put that in the chat box. And you can sign up for an appointment. It's very easy. It'll help you locate a navigator right in your area, and you can make an appointment right there online.
Wow. Allison, thank you. You know, this is again getting to that idea of economic insecurity that can make someone so vulnerable. And if you do have access to healthcare, what a great benefit that is. So thank you. And you're a wonderful part of our presentation. We appreciate you so much. I'd like to now turn it back to our other presenters and also ask you, were there any questions in the chat or in the Q&A that we should address now as as we pull up these questions. And Dr. Harrison, I know you always reflect on this at the end of our training programs. You want to open us up for questions and see what we have here?
Absolutely, happy to do that. But before we do so, there was a question that I don't know the answer to, and that was about whether there's an expiration date for a T visa. Is it a time limited?
It is a time limited visa, just like also the U visa. And Graciela, do you happen to know what that is, if it's 5 years or 7 years? It is a number of years. And if someone wants,
sure.
Yeah, if you want to put your name in the chat, I will get back with you, but I know it is time limited. I know that could also be extended. So we can get that precise information available to you. Any other questions?
That was the one that I couldn't answer.
Okay, thank you.
So I really do want everyone to just, whether you put anything in the chat or the Q&A or not, I really want you to think about the patients that you've cared for, your clients, your patients, and other people that you've interacted with, and what you might recall about them now. So it's my hope that we offered some little nugget of information that you hadn't considered before. But really, in the realm of trafficking, if you have suspected trafficking in the past about one of your patients, did you know to ask? What questions did you ask them? Did you provide resources, and what were those? And is there anything that you could take from our presentation today, or that you've learned in another venue, that would influence what you would do differently in the future if you had an opportunity to care for that patient again? I just, I can think of many, many patients that I would do things differently now. And I don't want anyone to think I should have been better, because we all continue to grow and learn. But I just want everybody to think about their own experiences and share with them with us if you're willing.
Thank you. And also, I just looked it up real quick. T visa valid for 4 years, and a visa holder may be eligible to apply for a permanent residence after 3 years in a T non-immigrant status. So 4-year visa. Thank you so much.